I think he's a good friend because he promised he would come back and visit Kenya, and he has not done that. So we're only meeting again for the second time today. But that's fine. That's fine. I'm sure he has an excuse and a reason why. Beyond that, though, Ali Habib is a senior digital health specialist at the World Bank, advising country teams on planning, budgeting, and implementing digital health components of bank finance projects. With over 20 years of experience and contributions, such as the Digital Health Blueprint Toolkit, he has supported the deployment of global digital public goods in more than 20 countries. Help me welcome him as he leads us through this fantastic session that is going to be brought to us by the World Bank. Ladies and gentlemen, let's give Ali Habib a round of applause as he comes to the stage. A bit louder, a bit louder. Woo! Thank you.
Thank you for the rousing intro. I hope it was worth the wait. I have not been here for a year, but I'll make it up to you, hopefully. Thank you, everyone, for coming in today. We'll be talking about, scaling digital public infrastructure for health approaches through implementable blueprints. And given the two of the plenaries we've had this morning, this is actually I was listening in on the morning panel that the World Bank hosted where we talked about primary healthcare, and the notion of interoperability came up, the notion of health information exchange came up. Similarly, in the full stack panel that was a little bit earlier, similar themes came out in those conversations, and people in the room were asking, okay, well, how do we do this? And at the World Bank also, we've been encouraging countries to think about health information exchange, interoperability, enterprise architecture for health. And it's all very well to say these things, right? But how do countries actually do it? And that's a little bit about what we'll talk today. And we'll have countries telling us how they're working on this today. So I'll skip this. So we launched the Digital Health Blueprint Toolkit last year at this conference, which is where I met my friend here for the first time. And at the time, this was a new resource. And the reason why we did this is because countries don't know how to implement health information exchanges, interoperable, at scale, at national scale. And yet, everyone tells them to do this, right? The advice we give them is do this. So how? And that's the key thing about the toolkit. It talks about the how, not so much the what. We've been talking about the what for the past 2 decades. This is about the how. And where possible, leveraging technologies like the WHO SMART guidelines, which you may have heard about earlier in this conference as well, to introduce quality into the healthcare network. And it sets up a roadmap. When you think, the approach is you think about where you want to go, where you are today, and from wherever you are today, it helps you chart a path for how you get to where you want to go. So it doesn't matter if you have 2 information systems running at scale, or 3 or 7 or nothing. Either way, you can use this tool, pick up from where you are and move ahead. But also, another theme that came up in 2 of the panels this morning was cost. So it's one thing to know how you do this. The other part of it is what it costs. And it also helps you to cost out what at first sight seems like, it's a big enterprise, right? Setting up, it's a multi-year, multi-million-dollar thing to put into place. But how many $1 million and how many years? And how do you figure that out? So those are the pieces that the toolkit helps you to understand. So the process is, and I'll go through this quickly because the point of this session is to hear from the countries, not from me, but it goes through 5 workshops where you basically establish the context of the country. Then you understand what it means to set up interoperability and standards in your country and what does that mean. Then it looks at what you have in place today and how you can leverage that as you go forward, which means you don't have to throw away what you have already invested in. So how do you leverage that? Then you think about implementation, the nuts and bolts of implementation, the brass tacks of it, right? Like how many facilities will generate ID cards? How often will my facility registry be refreshed? So the nuts and bolts of implementation, not just develop this and put it in the cloud, but how do you maintain it? And then finally, costing. And not just costing, but also investment modeling. So for too long, we've talked about digital health as a cost center. Digital health is an investment. It's not just a cost. And the toolkit helps you model what the return on your investment might be and when you would see it. So that's what the toolkit is about. And as an example, this is a generic architecture that the toolkit follows. It looks similar to OpenHIE for those of you who are familiar with that paradigm. But as an example, what we helped to do in Kosovo was to translate that into an architecture that was context relevant for where Kosovo was today and where they wanted to go. So that transformation is what this toolkit allowed. And I mentioned costs, and when you think about costing a national scale enterprise architecture, big words with big price tags. But how do you even start to break that down? In the Ministry of Health, how do you wrap your head around what it costs to set up something like this? And so one of the things that the toolkit has in it is an approach to costing, which breaks it down into these 9 different pieces, and it helps you cost out those pieces separately. So you break that big problem down into more digestible chunks, and you're able to get the full cost of what you're looking for. And we talk about a 10-year horizon, and this is important. These are not things that get set up in 6 months. They are not things that you set up in a year and forget about. These are things that have to be set up and maintained, and maintenance has costs, and for too long we've forgotten about the costs of maintenance and the costs of governance. It's all very well to say establish governance, and then you have no budget for your working group or your Department of Digital Health. So to plan that out. And then it talks about investment. So like I said, it helps you map out when you start to see an investment. This is a sample from a real country's exercise, where in the bottom half of this diagram, where you're seeing everything go green, at that point, every dollar you are spending on digital health is returning money to you. So your investment starts to pay off. And this tool helps ministries of health model what that return might be and how much am I getting back on every dollar I'm spending, and when do I see it. And so that is what we're here to talk about today. Now, since this toolkit was launched last year, several countries have used it, both supported by the World Bank, but also by partners like the Global Fund. In the room we have today representatives from Burkina Faso and from Rwanda, and online we have a representative from Botswana who will now be talking to us about their experiences. And to start that process off, I'd like to invite Dr. Salif Traore from the Ministry of Health, Burkina Faso, and Dr. Jai Ganesh Udayashankaran from AHIM to please join us on stage. And confirming that we have Mr. Chibani remotely. Okay, great. So we'll start off with a video presentation that Dr. Salif Traore recorded for us. And so if we can play that video.
Bonjour à tous, je suis Salib Traoré, je suis médecin de santé publique à la direction des systèmes d'information au niveau du ministère de la Santé de Burkina Faso. J'ai l'honneur de partager avec vous ce matin l'expérience du Burkina Faso sur le développement du dossier d'architecture d'entreprise en s'appuyant sur la boîte à outils, la Banque mondiale, qui a été mise en place à cet effet. Donc pour ce faire, je vais sur le plan suivant, donner le contexte, suivi de la méthodologie utilisée, donner un peu les aspects de l'architecture initiale que nous avons eue, et l'architecture cible, aussi donner le plan de migration que nous avons mis en place pour partir de l'architecture initiale à l'architecture cible, et partager avec vous quelques défis et difficultés que nous avons connus au cours de l'élaboration, et aussi les leçons apprises, en terminant avec une conclusion. Donc, comme contexte, il faut dire que la digitalisation, la transformation numérique est une priorité majeure pour le ministère de la Santé. Et c'est dans ce contexte que le ministère a mis en place un plan stratégique de santé numérique qui couvre la période de 2025 à 2029. Lors de la mise en place de ce dossier, de ce plan stratégique, au cours de l'analyse de la situation, ce qui est ressorti, quelques défis majeurs qui sont ressortis, c'est notamment la fragmentation des systèmes d'information et aussi l'insuffisance de la qualité des données. Donc, les défis majeurs, c'est vraiment de comment faire pour réduire cette fragmentation et aussi renforcer la qualité des données. Donc, pour ce faire, une action prioritaire a été identifiée, c'est la mise en place du dossier d'architecture d'entreprise et qui a pour but de mettre en place un système d'information intégré, interopérable, centré sur le patient. Donc, pour l'élaboration de ce dossier d'architecture d'entreprise, nous sommes alignés sur la démarche décrite dans la boîte à outils qui met l'accent sur la mise en place d'un groupe technique de travail. La mise en place de ce groupe technique de travail, et ce groupe comprenait en fait les acteurs du ministère de la Santé, du ministère de la Transition digitale, les acteurs du secteur privé, les acteurs de la caisse d'assurance, et aussi les acteurs, d'autres acteurs, notamment les autres professionnels et aussi les partenaires. Donc les outils que nous avons utilisés, il faut dire que la plupart des outils sont décrits dans la boîte à outils elle-même. Donc l'outil principal, c'est la boîte à outils. À l'intérieur de cette boîte, il y a la démarche et il y a d'autres ressources qui doivent être consultées pour la mise en place. Notamment, il y a le Global Digital Health Monitor qui permet d'évaluer la maturité de l'écosystème numérique. Nous avons aussi le cadre OpenHCE qui donne une démarche structurée pour renforcer l'interopérabilité. Il y a aussi le cadre TOGAF qui permet de faire une analyse systémique en suivant les différentes couches. Donc, de façon précise, le processus s'est déroulé en 5 étapes. La première étape, c'est la rencontre de cadrage qui a permis de mettre en place le groupe technique de travail qui est multisectoriel et aussi de finaliser et de valider ensemble en fait la feuille de route qui a conduit l'élaboration. À l'issue de cette rencontre de cadrage, il y a eu une analyse de l'existant. Tous les différents piliers de l'environnement favorable à la transformation numérique étaient scrutés, notamment la gouvernance. Nous avons aussi regardé tout ce qui est infrastructure, notamment l'énergie, la connectivité, il y a aussi les applications, l'interopérabilité et tout. À l'issue de l'état des lieux, il était question de faire le développement maintenant de l'architecture cible en s'appuyant sur le cadre OpenHCE et aussi d'autres normes, d'autres standards et normes d'interopérabilité pour conduire le processus. À l'issue de ça, il était question de mettre en place un plan de mise en œuvre. Donc le plan de mise en œuvre, c'est comment quitter l'architecture initiale, l'état initial, pour atteindre l'architecture cible. Donc il y a un plan de migration qui a été mis en place, suivi d'un budget, des investissements à faire pour en tout cas conduire cette transformation. Et à l'issue de ces activités, il a été question de faire une rencontre avec l'ensemble des parties prenantes aussi pour faire la finalisation et la validation. Donc en termes d'architecture initiale, il faut dire qu'il y avait une fragmentation du système d'information et on avait, en termes par exemple des applications, il y avait plus de 140 applications dans le système d'information. Et la plupart de ces applications sont centrées sur les programmes, les données des programmes. Donc nous avons aussi vu qu'il y avait une insuffisance d'interopérabilité qui se faisait de point à point entre les applications. Donc ce qui n'est pas une option optimale. Donc comme architecture cible, il faut dire que nous sommes basés sur le cadre OpenHCE qui décrit qui décrit en tout cas comment faire en sorte qu'on ait un écosystème intégré, interopérable, en s'appuyant sur les applications, notamment des points de service qui seront déployés au niveau des structures de prestations et tout, et aussi déployer les différentes building blocks, notamment les différents registres qui vont permettre de faire l'authentification et aussi de faire la standardisation des données, notamment le registre des terminologies, tout ce qui est actes médicaux ou les catalogues de médicaments qui doivent être standardisés pour permettre en tout cas de renforcer la communication entre les applications. Donc il y a aussi cette architecture prévoit d'avoir un entrepôt de données qui est le SIS, qui est le système d'information sanitaire qui reçoit en fait les différents indicateurs qui seront calculés à partir des données individuelles qui viennent en fait des applications du point de service. Donc il est prévu aussi un data warehouse qui va recueillir les données de masse, toutes les données individuelles pour permettre de faire d'autres analyses. Il est prévu aussi la connexion avec les autres applications, les autres sectoriels, notamment l'état civil, les assurances et tout. Il est prévu aussi la connexion avec le secteur One Health. Donc, à l'issue de la mise en place de l'architecture cible, il était question d'analyser les applications les applications existantes, comment on les réutilise. Donc, en fonction du cadre, nous avons défini les applications qui sont réutilisables. Et ce qui doit être fait, c'est décrit en fait dans le plan de migration. Donc, dans le plan de migration, nous avons prévu 3 phases. La première phase va concerner l'opérationnalisation des différents building blocks, les différents registres, et aussi l'adaptation des différentes applications du point de vue service. Il y a aussi la formation des acteurs et renforcement de la gouvernance. Deuxième étape, c'est de renforcer l'intégration des données, notamment en renforçant la standardisation, aussi en mettant en place une couche d'interopérabilité. Donc la troisième étape, c'est vraiment la maturité. C'est d'arriver à maturité, donc faire le suivi évaluation de tout ce qui est fait en termes de travaux sur les différentes applications et aussi permettre une recherche et développement pour l'innovation. Donc au cours de l'élaboration de ce document, nous avons eu des défis et des difficultés que nous partageons avec vous. Donc le premier défi, c'est comment faire en sorte que tous les acteurs, toutes les parties prenantes puissent s'impliquer, puisque le document doit être en tout cas compris, les acteurs de mise en œuvre doivent s'approprier. Donc il faut mettre l'accent sur la multisectorialité, impliquer tous les acteurs, toutes les parties prenantes. Aussi les ressources qui sont mises à notre disposition par la boîte à outils, il faut travailler à contextualiser ces ressources. Aussi, il est nécessaire d'avoir une assistante technique, ce qui donne un peu plus, ce qui permet au groupe technique de travail de mieux s'exprimer. Il y a aussi l'insuffisance d'expertise nationale sur certains aspects qui sont importants, notamment l'architecture d'entreprise, sur le cadre OpenArchive. Donc, quelles sont les leçons apprises? Il faut dire que la boîte à outils de la Banque mondiale est un outil de référence pour la mise en place du dossier d'architecture, car cette boîte nous a permis en tout cas de conduire de façon structurée ce document. Et aussi, il faut dire que la co-création qui est prônée par cette boîte à outils est une très bonne approche car elle permet de renforcer la capacité des différents acteurs et ça permet aussi de valoriser et de faire un alignement des différentes parties prenantes. Ça permet de faire la promotion de la mutualisation des ressources. Il faut dire que la conduite de l'élaboration de ce document doit suivre une approche itérative. Donc, il faut, en tout cas, à chaque rencontre, revenir sur certains aspects pour que le groupe technique de travail puisse être mieux éclairé et que les acteurs puissent s'approprier du document. Donc, en conclusion, il faut dire que ce document d'architecture d'entreprise que nous avons élaboré est un document de référence pour renforcer la gouvernance de la santé numérique au Burkina Faso. Nous avons conduit à travers l'approche qui est décrite par la boîte à outils, la Banque mondiale, qui nous a permis, en tout cas, d'avoir un document de qualité. Donc, ce document va nous permettre de renforcer en fait le système de formation à tous les niveaux, et permettre d'avoir les données de qualité pour la prise de décision, tout pour l'amélioration en fait de la santé de la population qui est le but ultime. Merci à tous de m'avoir suivi. Je vous remercie et excellente journée.
Dr. Traore, I want to highlight a couple of things. One, that it allowed the reuse of what Burkina Faso already had in place, which is very important. The other one was that one of the challenges that was highlighted was the lack of technical expertise in using the toolkit itself. And inviting now Jai from AHIN to talk about the efforts that we've been working on to actually help bridge that gap. Over to you, Jai.
Thanks, Ali, for the introduction. How many of you are aware of Asia eHealth Information Network? I think I do see many of you. That's very happy and heartening to know. Most of you are aware already. So I'll start probably very quick. Just a quick introduction that what we are. So we are a regional digital health network. If you want to understand what will be the area of focus in terms of geography, it is the two WHO regions of Southeast Asia, and then Western Pacific to be on the WHO regions. But we do have a global footprint. As you can see, that we have members from over 84 countries. And then, though we have multiple partnerships, done multiple things, but just to show you a glimpse of what we have been up to, like for example, our convergence workshops, where this blueprint actually neatly fits in. We actually work together with the Ministries of Health, and then we did these convergence workshops, and then we can see also the webinars. These are not technical experts talking, actually the experience from countries that are being shared, and then mostly from the countries, actually as partners actually sharing their experience, and then any one of you is free to join, and then the recordings of all those webinars right from inception is also available for access anytime. And then in terms of capacity building, as you can see, that we have done 27 cohorts of different training, starting with HL7 standards and also the interoperability standards, and then also talking about the governance frameworks, whether it is TOGAF, Accumate, or Prince2. We have provided a variety of training and capacity building platforms. But then, I would like to actually link this bootcamp the process actually brings all those various trainings and capacity building measures into that. So that's something that I will actually also bring it in later. Just to give you a glimpse that who we are and what we did. And again, linking to blueprints. Our work together with the World Bank started quite some time ago. And then as you can see, this topic in Jakarta that we had our general meeting, some of you are here in the audience, were very much part of that conference actually. Why this topic? Because we did see in our region multiple countries, they are either developing the national digital health blueprint, or they are implementing it, or in the process of that. Then we saw, like, now we know from WHO also recently we listened, I think WHO colleague is right here, right on time also. We have 129 countries that have the national digital health strategies. But then looking at like how many of them have actually taken that strategies to implementation, that's where the costed blueprint, resourcing it, having those resources, whether it is human resources or the financial resources required to take that to implementation. And Ali mentioned about the 10-year roadmap for that. That actually becomes relevant. That's where AHIN actually comes into the picture, working together with the countries. If they have a national digital health strategy already in place, if that is not functional, then we work together with them, convene the multi-stakeholder convergence workshop to get everybody on board to see the national big picture and get them to implement. If the implementation is already in process, then also to fix those gaps and revise the strategy if required. Again, we use the convergence workshop. That's where the blueprint neatly fits in, and this is one of the efforts that we did. We started working with the World Bank team. If you can see, like maybe from the next slide, this is like the webinar that we had with the World Bank team when the blueprint was actually in the drafting stage. And then they were part of actually our general meeting in Jakarta in 2023. And then you can see another webinar. This was like right at this forum last year, this blueprint was launched. So immediately after that, and then the vacations and things like that, like we had this blueprint actually shared with our members. So it has been a continuous process of working together with the World Bank team. And then this actually led to this blueprint boot camp that happened in Manila just a month ago, between 4 and 6 November. And we had this open process, and then people applied for it, and then we had a variety of participants who qualified for that, and then we had 54 participants from 20 countries joining us. And then broadly, I will give the objectives because Ali has already shared. This is to learn how to actually facilitate this toolkit, and then also how they can help the countries in the region. And then another objective was to create a pool of trained facilitators. Again, I'm sure that everyone is aware, there are so many digital health tools, frameworks. This is not meant to be yet another. This is, I wouldn't even say a living document. I would say it's a process. So our aim was to create this pool of facilitators in the region who could actively work together and contribute in their own digital health blueprints in their own countries, and then the region as such. And then also to form a community of practice where these trained facilitators can actually engage and learn from each other and support each other. Those were the broad objectives. And then it was held over 3 days, like Ali actually mentioned about various things that goes on into the blueprint. So this boot camp actually did that over 3 days in form of multiple workshops. So in the day one, we had the context setting, the various use cases, the health information exchange, specifications, and then the day two, we had the various digital health building blocks. The focus was on that, and then the implementation science. So as we had this very interactive, intense workshop over 2 days, on the second day, it became, I would say, a lot of questions started coming. So it was not like more like a presentation mode. It was a continuous engagement with the participants. So people started relating to their own context, where they are in the journey, and then the questions started coming up. I think it was also one of the previous presenters mentioned about the technical working group. There were questions asking us who should be there in the technical working groups, how it should be formed, how it should be managed, and then also the costing. And then the day 3 is about costing and investment rationale. Again in AHIN, we had done a lot of trainings that is mostly about the standards, interoperability, governance frameworks, project management, but then the costing was always an issue. And then most of the time, how do you do the costing? I think most of you are aware, right? There will be a grant, and then there will be pressure to do the costing, and something is done. But we have always been actually advocating countries to do the total cost of ownership, because if you don't do that, I think the projects get stuck, or the national digital health programs get stuck. This was very helpful on the day 3, especially talking about the budgeting. And then again, in terms of the trainings that we did, this was actually a gap that we had. This boot camp actually filled that part in. So of course, like we do have plans to actually take that costing part as more into further webinars and work together, because that's a more intensive part. And then this I would like to highlight because, as I said, countries are in different phases in terms of the blueprint. So as you can see, this we did as a pre-poll. So even before the boot camp, the moment the participants were onboarded, we did this quick survey to see among the participant countries where they are. So as you can see, some are in the development phase, some are still thinking about it, some are already in the implementation phase and things like that. And then what are the key insights? Again, as I mentioned, there were a lot of questions about the technical working group. And then, of course, we were also able to relate with our convergence workshop experience to say who could be in. And then, this kind of a suggestion is a recommendation, of course, depending on the country context and then how the digital health is governed, it also varies. And then about the understanding of the toolkit contents and templates, there were a lot of questions needed because to contextualize this toolkit to the country context, because I think that's also important for people to start using the toolkit. And then we had about health information exchanges and establishing the communities of practice. And then, of course, preparation for artificial intelligence inclusion. I think this is a very important thing because in AHIN, again, we get a lot of requests from countries, hey, I have a national digital health strategy, but we also have an AI strategy. Can you actually help us to work together and harmonize it? So this feedback was really helpful for us to see when we do this blueprinting process, how we could bring that in early on. So the community of practice again. I would like to highlight this because AHIN has done several trainings, as I said, 27 cohorts of different trainings. Again, unless otherwise, these trainings or skills that are built in or put into practice, it has no meaning or people actually lose the touch. That's why in the last few years that what we have is like when we select the participants, we also have a re-entry plan. If they go back after the training, do they have a plan to implement in their own countries? This is something that we build in. The community of practice exists because they need to actually talk to someone and then say, hey, I'm working on this, and then update each other, and they may have solutions or mostly problems, how each one has tackled that. So this is the community that we have built, and every training cohort that we did resulted in the community of practice. This is something that we announced on the last day, and then we had, I think, among the 54 participants, over 40 of them already signing up. So we will very soon, I think within a week, we are going to have this meeting with the community of practice to get it going. So I don't need to actually explain why it is beneficial, but as you can see, how this blueprint fit into our own work in the region, and we actively look forward to continue to take working together with the World Bank team and of course other partners to make sure this is actually being used. Thank you very much, Ali, and everyone for this opportunity. Thank you.
Thanks very much, Jai. And because in this session we will use every presentation modality known to man, we now have a remote presentation. So we're trying everything out today. Over to Mr. Chibani from the Botswana Ministry of Health.
Well, good afternoon, distinguished colleagues, and it's an honor to share Botswana's journey in developing and scaling our national digital health blueprint, a process that reflects our ambition to build a sustainable, resilient health system through digital public infrastructure. Next slide, please. Well, the journey started with within really a concern across the health sector with regards the health information systems in place and the monitoring and evaluation. So in 2019, we had that opportunity to just do an assessment of the health information systems across the health sector, and also looked at the digital sort of tools that we have in the health sector. So commonly, a feature that was repeating itself was, underreporting, across the health sector. But also this was mainly due to another challenge of fragmented data systems. In the public sector, for example, you would have a plethora of these registries being expected to be used by our health practitioners on the ground. ranging from, like 20 to 43 of these registers. So it was quite a messy situation on the ground. So it is indeed a testimony that we did recognize early that digital health requires a structured approach. And our blueprint ensures interoperability, sustainability, and alignment with both national priorities and continental frameworks. I think for us, whenever we looked at issues around health statistics, for example, it was important that we needed to be able to know, readily information to do with morbidity and mortality in country, and we couldn't really be able to get that. So all these challenges, I think, would lead us to the next slide so that I can be able to define what we did. So we adopted the WHO toolkit for the digital health strategy, which was looking at various building blocks for a digital health in country. So leadership and governance as a pillar is something that we did not really compromise on. We onboarded our leadership because we knew that to be able to drive most of these solutions, there was need to have, the voice at the highest level. And in our country, we are blessed, especially with the, Office of the Presidency in that regard. And it literally managed to cascade easily to the ministries, where the ministers of, for example, of health was now keenly responsible for digital health. So the other areas I think that we looked at is how through the health sector, we could be able to ensure that, investments can be used effectively, whereby, in-kind support, from other, stakeholders within the health sector could be looked at in order for us to be able to build a digital health platform that will be suitable for the health needs within the country. But some other pillars that we looked at, especially services and applications, to be able to advise the health sector on areas on how, we can be able to improve in, developing the applications that can easily share data. And we presented especially the standards and interoperability pillar to the entire health sector, really to be able to share with them that it is important that there should be a point of convergence. When we talk about a citizen enjoying health services, we should be able to be broad about, the data that is collected on that citizen, especially health data. But below all this was the infrastructure. How also as the health sector, other stakeholders could be able to contribute to ensuring that we build a very robust infrastructure in country. But obviously, all these things, they needed policies, and we banked very much on the digital policy for the country, known as Maitlamo, which really gave us the direction in terms of what should be done. So not to leave behind the, the professionals that are going to be utilizing and also developing these tools, there was a very sustained way in which we could be able to, train our users on the ground to adopt these technologies. Next slide, please. Now, why a digital health blueprint? I think the World Bank came at the right time when we are still grappling, with issues of how we could really translate the digital health strategy that we had into really action. And I think the framework that was presented to us really gave us a good sort of a base for us to be able to push most of our projects. And it helped us operationalize national health strategy that was in place. And it showed that at least we could be able to do interoperability as much as it was required. But also it allowed us to align with, the global digital public infrastructure principles for sustainability and scalability. And within that framework, I think this is how we could be able to submit most of our projects that World Bank could be able to fund. So I would say that these components form, especially in the next slide, the components that we'll be discussing, they really form the backbone of our blueprint. And the enterprise architecture is the key deliverable that our digital health strategy looked at, that this is something that we have to have in place in order for us to be able to rally the entire health sector behind one, health information system, one monitoring and evaluation system. So governance and policies I've been able to mention. I think we have leadership now within the ministry that is really driving most of the digital health activities in country. But the other item that is a very key component is the infrastructure. I mean, within the public sector, for example, we have what we call the government data network. This is it's a wide area network that allowed all the ministries, to enjoy connectivity across, the country. But obviously, the reach of it is still needs to be improved. But as such, we could be able to use the government data network, for example, to support electronic medical records. Like at all our hospitals in Botswana, we have a very robust EMR that is actually running on this government data network. And for us, as we were now looking at developing other components, especially that would allow us to interface this system to other national systems. I think the infrastructure was improved in that regard, because as the country, we have already the Botswana government, architecture that really is robust enough to cater for all our needs. So I think for capacity building, it's quite apparent that the health workers who are the people that are generating a lot of data on the ground, that we needed to make them as much as possible as comfortable on these tools. So the blueprint, as it stands there, it does cover various things that we could be able to leverage to ensure that we really improve the digital health competencies amongst our workforce. So I think the same applies with the core teams at the ministry, for example, that we are using as in health informatics and IT, for example, to ensure that we are adoption of all the solutions can actually be sustained. Otherwise, I think we are building these tools for our patients in order for them to have good experience with the health services that we are providing. So for us, I think the blueprint has provided that framework in which we could be able to really sustain that requirement. Next slide, please. So I can be able to indicate to you that as part especially of the digital health enterprise architecture that we came up with, we identified clearly, within the health sector, in the private sector, the public sector, and also areas like specialized areas like CMS or central medical stores, the kind of digital tools that are existing. And I would be able to highlight that because of this messy situation, you see that the data warehouse enjoys some point-to-point connection with some of these digital tools. And for us, I think in terms of the situation where we find in some of our facilities, especially the clinics and the health posts, still using a standalone application, it meant that we would not be able to enjoy the real-time information that could be ingested into the data warehouse for any form of business intelligence that is required, to generate analytics that are required, especially by by decision makers. So as it stands, you can be able to see that this is not something that we could continue with. So as a country, we looked at the blueprint and how we can be able to ensure that we really create a very robust digital health ecosystem. So this can be presented nicely in the next slide. So as it shows there, this is where, as a country, we are going, and some work has already been done, especially to ensure that instead of actually a point-to-point connection between our digital health tools, we have health information exchange, forming the middle layer in which you could be able to ensure that you interface various systems. For example, any citizen in Botswana is identified by, there's a national ID that identifies a Botswana, and that is hosted in an environment within another ministry, Ministry of Labor and Home Affairs. So we are using the health information exchange in this. When a client shows up at our facility, we can now easily be able to identify that person using the ID that he will be presenting. And the health information exchange has allowed us to build, for example, an open MRS solution that would query the client registry to ensure that it can be able to bring all the demographics about that client as quickly as possible. But if it doesn't find within the client registry, for example, the required details, then that's when the EMR doesn't have to talk now with the Oman system like in the previous baseline architecture, where there was a point-to-point sort of connection between these two data sources. So you would have the health information exchange being the one that is responsible for querying the Oman or the national ID system to be able to get the details about the citizen. So the same applies if is using a passport number, for example, we can be able to query the immigration system for this information in using a similar fashion. So this is the direction that as a country, all the investments are really pointing to. And the World Bank with its blueprint actually has really helped us in costing and ensuring that we can be able to sustain most of the solutions that are going to emerge from this arrangement. Next slide, please. So this is what I was trying to explain in terms of the client registry or the master patient index, whereby at the facility, for example, whether it's a public or a private EMR that is being used, it will be able to just go directly into the health information exchange client registry or MPI to get the details about a client. And this, as it stands, I think it's something that is going to really help us, especially in building also a longitudinal record of a client, so that most of the data can actually be pushed into another registry known as the shared health record, which as a country we want to really have in place so that we can improve sort of the health status of this nation, whereby we really use data for clinical encounters. Regardless of where this data is lying, the importance of actually having a complete, data or history or clinical history or medical history about this client is very critical for us. So I think for us, the health information exchange is really the core of everything that we are doing in country to ensure that we can be able to provide uniqueness amongst our clients and also be able to have all the necessary information that is required for the next encounter with the clinician. So going into the next slide, so that we can. So the implementation journey, as it stands there, it's in a phased manner, since planning and even to piloting the solution that I alluded to, the open MRI solution, to our clinics and health posts. It was done in a phased approach, whereby we piloted this system within, the nearest, facilities where we are based. And later on, we deployed the successfully piloted application to the other 2 districts out of 31 districts that are in country. So we are looking at actually now at these 2 districts in terms of how they are performing with this open MRS solution, with the intention that in the next financial year, which begins next April, we should be able to now roll the entire open MRS solution to all the clinics in the 29 districts. So this journey really has obviously encountered some challenges, like we know connectivity, but I think building on some of these things it requires partnerships. And I think with the World Bank arrangement and the partners that are in country, especially through the shared infrastructure, that is ongoing in country. This is something that we are currently resolving. So in terms of solutions that are in place, we can be able to see that we managed as a country to ensure that the health sector can always come together on issues of digital health by coming up with a TWG, a technical working group, that meets on a quarterly basis to really discuss pertinent issues around digital health and what needs to be done, especially as different sectors in Botswana, to ensure that we are on the same, page in terms of what we are trying to drive with digital health in country. So these are this journey that currently we are pursuing. And I would be able to say that we have moved, for example, the HL7, which was predominantly what we were using within our system. We've been able to move to the FIRE standard, which is, the latest version, especially of HL7, that as the health sector, we've been able to really agree that this would be suitable for, data exchange between our systems. And I think through the TWG arrangement, we've been able to successfully really involve all the stakeholders within the country. And going into the next slide. Well, one key takeaway is that a blueprint is a living document. It must adapt, and as in our country, I mean, there are some changes that are taking place, and we believe that we would not just be restricted by the direction that the blueprint is showing if nationally there are some other, things that needs to be done in order to really allow the Ministry of Health and the health sector to be relevant to anything that is being done across the sectors in Botswana. So interoperability and stakeholder engagement, they are really essential. And we've been able to find that that regional sort of alignment amplifies national progress. I mean, we're working with, Africa CDC, for example. Some of the frameworks that we have been able to embed, especially to ensure that regionally we can be also relevant, especially in terms of surveillance or disease surveillance. It's important for country, cross-border, disease management that we need to be able to conform to what other countries are doing. But as I've indicated, really the importance of ensuring that the stakeholders or the policymakers, health workers, part of the whole thing that we are doing, this is through the digital health principle of co-creation. We do not allow them to be left behind. So most of the designing of everything that we are doing, we allow the end users to be at the forefront, because with experience, we know that technical leadership has always ended with failed projects, and stakeholder buy-in for us is critical. So going into the next slide, I think I should be able to say the really Botswana blueprint demonstrates how structured and implementable plans can transform healthcare delivery. So by embedding the digital principles, and especially the digital public infrastructure principles, we are contributing not only to national health transformation, but to Africa's broader digital future. So I invite collaborations as we continue this journey together. I thank you for your listenership. Thank you.
Thank you very much, Mr. Chibani. We did have a panel plan, but we're running up against the clock. Can we go on for an additional 5 minutes beyond the time, or do we have to stop at time? Okay, great. So we'll do an efficient panel. They said the World Bank is not agile. We'll prove them wrong. So if I can invite Amanda Bendor, digital health advisor at the World Bank, and Benjamin Nitigega on stage. Sorry, I mangled your name. I apologize. Have a seat. Those are my notes. Sorry. No worries. Okay, so we don't want to keep people from lunch, so we'll be efficient. I want to start with Benjamin, who works with the Chief Digital Office in the Ministry of Health in Rwanda. And they are in the process of developing a blueprint. And so, Benjamin, can you share a little bit about Rwanda's blueprint process, where you are today, but also how has the toolkit been useful, and how have you kept the work going while simultaneously scaling up interoperable applications? So I've lumped up a few things in the interest of efficiency.
Yes, thank you very much. Good afternoon, everyone. As the blueprint, World Bank Digital Health Blueprint Toolkit was introduced last year in this summit, it already found us having the foundation of the past five to 7 years of the work that the ministry was doing around digital healthcare transformation. So what we are now doing, we are referencing it to develop now our digital health blueprint for the next 5 years. We are using the key component like the enterprise architecture and the governance model into our new digital blueprint to ensure that for the next 5 years we are going to align with the global standards. So, but in summary, you've seen the presentation of how the components of the blueprint are. We will in that same direction. So we had already adopted the health information architecture. We had already had a clear governance model in the country, whereby the Ministry of ICT in Rwanda embedded the team of professionals into the Ministry of Health. So that has really shaped the country's vision for the last 5 years. We moved from fragmented program-specific systems to a more connected and centralized architecture. Thank you.
Thank you for that, Benjamin. And over to you, Amanda. So you've been supporting some countries yourself with the use of the toolkit. In particular, for example, St. Lucia, who we actually wanted to have here, but they could not travel. So we're hoping you can represent. If you can share some of your experience using the toolkit, but also I know that you've been looking at all the feedback we've been getting from all the use of it, as well as the boot camp in Manila. If you can say a little bit about your experience, but also where we are taking the toolkit now. Thank you.
Sure, thank you. I will say writ large, people are really appreciating that this is a process. This is a how. It's grounding in health and health priorities and really looking holistically, not just at a schematic architecture, but all of the components that you need to develop a enterprise architecture, a blueprint, and sustain it. I've had the pleasure of working with the Ministry of Health in St. Lucia for the past several months. As they have been going through this process, they've gone through 3 of the 5 workshops so far. And I will say this has been a fortuitous time for them because they have just launched their first national digital health strategy. They have just updated their national health strategy and policy. And then they're incorporating all of that in developing their first digital health blueprint. And so this has been a really critical time for them as they've been scaling a lot of these strategic processes. They also have given us feedback about how useful it is to have the process and engaging the technical working group. And I've also been really pleased with how quickly they engaged their technical working group to go through this and how they've kept momentum up. I'm on a WhatsApp with them. And they keep in touch throughout this process. And actually, just this week, they shared, we've updated our digital tools to the Digital Health Atlas. We've shared with the Global Digital Health Monitor our national digital health strategy. So just a lot of synergy there. And the key for St. Lucia is having a fantastic local facilitator guide them through this process. And I think that's a key for any country. Someone who really knows the local context, who knows the systems, who knows how to talk to that technical working group and how to navigate them and guide them through this process. And just to reflect too on other things that we'd like to think about for the future for this toolkit and other things that we've been hearing back, a lot about the costing piece and how to make that a little bit more easy and feasible and putting more direction into that. So we're hoping to provide some updates in future iteration of the toolkit next year on guidance for the costing, but also the technical working group. Some countries have a technical working group, others don't. They're convening a technical working group for this. And, Jai mentioned this, but we want to be able to provide some guidance and information on what does that look like? What's the process? What's the composition? And so we'll be looking to do things like that in the future.
Thank you, Amanda. And also on St. Lucia, the process is being led by 2 powerhouse women, which is there's a lot to be said for that.
Yes.
And for our last question, Benjamin, over to you to close us out. We recently heard about the release of the Smart Africa Blueprint, and you've been involved closely with that. Do you want to share something with the group about your involvement, but also where you see that going?
Well, thank you very much. First of all, it's really exciting that now for the first time we have a same clear direction as African countries around digital healthcare transformation. And then another excitement is that as Rwanda, we are part of the contributors and part of the team that developed the strategy. So as you are championing it, it comes as a way of setting the stage for a single digital health market across Africa. Imagine the patient coming from Rwanda without having fear of their continuity of care in Kenya. So if the clinician in Kenya can have access to my past records, that will make informed clinical decisions. And then as well, it also introduces a new door for innovators, our health tech companies. So if they are developing solutions using the same standard, the same architecture principles, that means a solution developed in Kenya can be scaled to Ethiopia, can be scaled to Morocco. Only a few tweaks or a few customizations will be made, not starting from scratch. So that's a win for us, the part of cross-border data sharing, the part of our innovators now scaling across other countries without really needing to start from scratch. Though that makes a clear pathway to a single shared digital health market. Thank you.
All right, I think that brings us to the end of our session today. We don't want to hold you back from lunch any further. Thank you for bearing with the additional couple of minutes of time. Thank you all. I think we have to stay on for a photo, but thanks everyone for being here. And we're all here over the next day or so. So if you have a question for any of us or the panelists, please find us. We're all here. Thank you very much.